In this week's Cardiology Countdown, we start with a new paper in JACC on pro-BNP 1 through 108. This is the precursor found in the myocardium, and normally assays will pick up one of the two cleaved portions of pro-BNP. The concept was that this precursor might be found in patients normally and might provide new insights into the processing of BNP. And so the Olmsted County cohort was assayed and found that there were, in fact, low levels of pro-BNP 1 to 108 in the general population that changed as patients developed systolic heart failure. And so this will be a potential new insight into the processing of BNP. And so stay tuned and follow more on the biomarkers clinical community on CardioSource on this new biomarker. At the number 2 spot is the quality of life sub-study from the SYNTAX trial. As you know, this was a trial of PCI, multivessel PCI versus CABG in patients with left main and or 3-vessel disease. And this looked at the quality of life questionnaires done at baseline and 6 and 12 months. And so the findings were that both groups had improvements in their Seattle Angina questionnaires, not surprisingly, but that there were greater improvements in the CABG patients at 6 and 12 months. And looking at the percentage of people who were free from angina, this was more at 12 months in the patients with CABG, although it was a modest difference, being 76 to 71.5%. Now, on the other hand, other parts of the Seattle Angina questionnaire that looked at other parts of quality of life were better early on for the PCI group. And so this study quantifies some of the things that we would otherwise have guessed from the SYNTAX trial. And of course, we're all looking forward to seeing longer-term results and other upcoming trials in this ongoing question of multivessel PCI versus CABG. And at this week's number 1 spot, published in JAMA, are the final results from the GRAVITAS trial. And this looked at using platelet testing to identify clopidogrel non-responders, or low responders, and randomize them to standard dose clopidogrel or high-dose clopidogrel, that is 150 milligrams a day, for a 6-month period following drug-eluting stenting. Now, this was presented by Matt Price at the AHA, and the final results showed that there was no difference in clinical outcomes in the high-dose clopidogrel group when compared to standard clopidogrel in these non-responders. Now, I was a member of this study group, but some of the issues with the trial are that just a modest-sized trial, a little over 2,000 patients, but just 50 primary endpoint events. And so other studies will be helpful to move this forward. The editorialists pointed out this was a good first step. Some take-home messages are that at present, if one did test and identify a low responder, one can find these data to say that you're unlikely to get much clinical benefit from doubling the dose of clopidogrel, and one might want to think about a stronger antiplatelet regimen such as prasugrel. But further trials using stronger interventions for the low responders are ongoing, and so we'll all stay tuned for further trials in this area. So with this week's Cardiology Countdown, I'm Chris Cannon.